It's a plenary lecture. The lecture will be Professor Raul Santos. He is the president of the International Society since 2019 to 2021. He is a member of the consensus panel on dyslipidemia of the EASD. He is a director of lipid clinic of the Heart Institute in Sao Paulo in Brazil. And he is a researcher at Albert Einstein Hospital in Sao Paulo in Brazil. Professor Paul Santos is one of our friends. He was attending our meeting last year by himself, and his talk will be on PCSK9 inhibitor on cardiovascular disease prevention. Now we'll listen to the lecture of Paul Santos.
Assalamu alaikum, my friends. This is Raul Santos from Sao Paulo, Brazil, and from the International Atherosclerosis Society. I really like to thank you for inviting me to participate in your Congress this year. Unfortunately, I'm not able to be in Egypt, but I do hope that in the future we will all be able to congregate together. So the title of my talk will be PCSK9 inhibitors and prevention of cardiovascular disease. So this is my conflict of interest with some pharmaceutical companies, and the idea is really talking about the role of cholesterol as a cause of atherosclerosis, the residual risk despite the fact that we reduce it, and then we will discuss about PCSK9, how this came from genetics to clinical practice. We will discuss how this protein works, the efficacy of the treatments, how this influences on the prevention of cardiovascular disease, discuss how to identify individuals who get a greater benefit from the treatments and show better cost effectiveness, discuss the safety of either the monoclonal antibodies and also the very low LDL cholesterol levels attained, and discuss a little bit about the future. So we all know that cholesterol is an independent cause of cardiovascular disease. So this evidence is really robust, with almost 800,000 patients that were enrolled in interventional clinical trials that lasted by 5 years, observational clinical epidemiological trials that lasted by 12 years, and the so-called Mendelian randomization trials that lasted up to 52 years. And it's clearly seen from all these trials that actually the longer your cholesterol is lower, the lower will be your risk of events. And the contrary is also true. For, let's say, for a difference of 1 millimole per liter or 40 milligrams per deciliter in LDL cholesterol, in 5 years, that means a difference in 22% in the risk of events. In 12 years, that will mean 32% difference in the risk of events. And in 52 years, it will mean a 50% difference in the risk of events. So the earlier you lower the LDL, the better for our patients. And actually, statins really changed the way how we practice preventive cardiology. And these drugs are still, in my opinion, still will be for a long time the cornerstone of treatment. So let's say that if you use a potent statin and we reduce the LDL by 2 millimoles per liter or 80 milligrams per deciliter, and if we treat 10,000 patients for 5 years, we will prevent 1,000 events in those who already had a cardiovascular event in the past, and 500 events in those in primary prevention. So that means a 10 and a 5% respective absolute reduction in the risk of events. As any medication, statins might have adverse events, but I can state to you that actually these are one of the most safe drugs that we have in clinical practice. For the same 10,000 patients that will be treated for 5 years using a potent statin, a good dose to reduce LDL intensity, let's say Torva 40 or rosuvastatin 20 milligrams, it will be expected to occur 5 cases of myopathy. I'm not talking about muscle pain, I'm talking about myopathy. The precipitation of 50 to 100 new cases of diabetes. Statins don't cause diabetes, but they might precipitate diabetes, and 5 to 10 hemorrhagic strokes. 5 to 10 hemorrhagic strokes in 10,000 patients means 0.05 to 0.1%. And this has nothing to do with intensive LDL cholesterol reduction, but probably has to do with the antithrombotic effects that these medications have, especially in predisposed patients like those who already had an hemorrhagic stroke in the past. So statins make the difference. They reduce the risk of cardiovascular events and mortality. However, many patients will still persist having recurrence of events. Of course, this might be attributed to high blood pressure, persistency of smoking, diabetes, high triglyceride rich lipoproteins in the plasma, inflammation, and so on. But we know that actually, even if we go more aggressively with LDL cholesterol reduction, and now we have evidence that if we go to values of LDL of 20, 30 milligrams per deciliter, actually we will have a greater benefit. And this is so-called the LDL cholesterol-driven residual risk. So indeed, we need further LDL cholesterol lowering in those highest risk individuals. And actually, PCSK9 inhibitors really came to change the way how we do prevention when we're talking about reduction of LDL cholesterol. So we have evidence that PCSK9 probably was, the science behind PCSK9 probably was one of the most, let's say, robust and fast that we had on this century. So in 2003, Mariana Bifadel at the group of Catherine Boileau and Dr. Nabil Seida actually described individuals who had the phenotype of heterozygous FH but didn't have variants in the LDL receptor or ApoB, and actually they had gain of function variants in the PCSK9 gene. On the other hand, on the contrary, Jonathan Coyne in the United States in the ERIC study actually showed that those individuals who have loss of function mutation in the PCSK9 gene actually had lower LDL cholesterol and had a lower risk of cardiovascular events. From there, the science developed very quickly, and now we understand exactly what PCSK9 does in the regulation of LDL cholesterol levels in the plasma. So basically, PCSK9 is synthesized in the liver, in the gut, in the kidney, and is secreted into the circulation. There, it binds with the LDL particles and also with the LDL receptor. And this complex, LDL receptor, PCSK9, and LDL actually enters the liver, and the LDL receptor is driven by PCSK9 to be degraded at the endoplasmatic reticulum. So basically what PCSK9 does is reduce the recycling of the LDL receptor and leading it to degradation. And then we understand why if we have excess of PCSK9 in the circulation, we will have a reduced expression of the LDL receptor in the hepatocyte surface, and we will capture less circulating LDL, and therefore LDL will be higher. On the other hand, in loss of function variants of PCSK9, we will have reduced secretion of PCSK9 into the plasma, less PCSK9, and we will have a greater expression of the LDL receptor and consequently reduced LDL cholesterol levels. And actually, let's say in less than 15 years, there was development of medications that actually could take the circulating PCSK9 from the blood. And actually now we have two monoclonal antibodies that bind to PCSK9, evolocumab and ilerocumab. These are fully human monoclonal antibodies. We also now have a small interference RNA that I'm going to discuss with you later that's called inclisiran, that actually works not in the circulating PCSK9, but actually blocks the production of PCSK9 in the liver. And actually this was the easiest way, the monoclonal antibodies, to really block PCSK9, but we also have another ways of doing that, as I'm going to discuss with you later. So basically what the PCSK9 inhibitors do, they bind the circulating PCSK9. There will be less, in this complex will be degraded, and then there will be less PCSK9 to bind LDL and to bind the LDL receptor, and consequently the recycling of the LDL receptor will be increased, and we will have a greater capability of taking away LDL from the circulation, and LDL will drop very intensively. So this is data from one of the drugs that we have available, evolocumab, and you can clearly see here that independently of the treatment for hypercholesterolemia, diet alone, low or high dose atorvastatin or high dose atorvastatin associated with ezetimibe, there will be a similar relative reduction in LDL cholesterol between 50 and 60%. Of course, if we add a PCSK9 inhibitor to high dose statin and ezetimibe, we're going to have additive effects in reduction of LDL cholesterol for these patients. And of course, we will use this mostly in familial hypercholesterolemia patients. And this is very interesting and elegant study, actually showing that when we do a kinetic study in healthy subjects before and after alirocumab, when we inject the monoclonal antibody, we will have an increment in the clearance of either LDL and also IDL, the precursor of LDL. So basically, we're going to take away LDL and the precursor lipoprotein. So this will explain why we will reduce LDL cholesterol, because these particles are taken away by the LDL receptor. So actually, probably the individuals that will get the greatest benefit, and actually are those that are most in need of PCSK9 inhibitors, are those who have familial hypercholesterolemia, because we know that even using statins, high dose, ezetimibe, less than 20% of heterozygous FH patients will attain an LDL less than 100 or 2.5 millimoles, and less than 10%, than 5% will attain an LDL less than 70 milligrams per deciliter or 1.8 millimoles per liter. And worst of all are the homozygous FH patients that still persist with extremely LDL cholesterol levels. And actually, this is data we have published at the beginning of this year. 300 patients with either homozygous or severe heterozygous FH. Patients were treated by a mean 4.1 years. And actually, we can see here that in the heterozygous FH, even severe ones, there was around 55% reduction in LDL cholesterol that persisted for up to 4 years of treatment. In the homozygous FH patients, we had an around 20% reduction in LDL. The drug was very well tolerated. There was not appearance of neutralizing antibodies, and actually the rates of cardiovascular events of these individuals were much lower than controls that didn't take PCSK9 inhibitors in previous studies, so suggesting that actually PCSK9 inhibitors can make the difference for the FH patients. Of course, for the homozygotes, it's more complicated. Recently, we have published the first randomized clinical trial in pediatric patients with heterozygous familial hypercholesterolemia. These patients were taking statins and ezetimibe and persisted still with LDL cholesterol levels over 3.5 millimoles per liter or 130 milligrams per deciliter. And they were randomized to receive monthly injections of evolocumab for 120 milligrams or monthly injections of placebo. And we can clearly see here that after 24 weeks, there was a 38% relative reduction in LDL cholesterol in comparison with kids that were randomized to placebo. The drug was very well tolerated, and there were no changes in hormones, vitamins, growth, Tanner staging. Of course, just 6 months of treatment. These kids are being followed up to 2 years, and so far we have no adverse signs of the treatment. So suggesting that we might have also option for these more severe FH patients, in pediatric patients that don't respond adequately to statins. However, most important is not to reduce cholesterol, but reduce the risk of cardiovascular events. And actually, we have very robust studies that clearly show that. With thousands of patients that were enrolled in either FOURIER and I'd say outcomes patients, high-risk patients, secondary prevention patients that were already taking statins, that had LDLs around 90 milligrams per deciliter at baseline. These studies reduced LDL between 40 and 50%, and there was an additional 15% relative risk reduction in events, mainly driven by reductions in myocardial infarctions and strokes. There was no reduction in mortality. However, the rates of mortality in these studies were low. And as you can see, the studies were short. They lasted on average 2 to 3 years only. So the question is, okay, these drugs can reduce cardiovascular events, but they're expensive. So how can I increase the cost effectiveness of my treatment and really make my PCSK9 inhibitors really, let's say, the investment to really pay what we're investing on them? So basically, we have some individuals in secondary prevention that actually have a much greater risk of recurrence of events than other ones. So basically those who have a high burden of atherosclerosis, so usually those who have 3 vessels, 3 coronary arteries with plaques, those who have atherosclerosis in other territories in addition to the coronaries, let's say peripheral artery disease, carotid disease, or those who have diabetes who have a greater burden of atherosclerotic plaque, or those who have greater activity of atherosclerosis. Let's say those who had a recent acute coronary syndrome, diabetic patients again, those who have elevated C-reactive protein have low-grade inflammation, those who have elevated lipoprotein A, and those who have genes that might predispose to a greater risk of events. So individuals who have these clinical characteristics will have a much greater risk of recurrence of events and will have a greater benefit of a reduction of cholesterol with PCSK9 inhibitors. So I think that for you endocrinologists, this is the population number 1. Diabetic patients who have cardiovascular events have a much greater risk of reduction of recurrence of events than non-diabetic patients. And for the same relative risk reduction of events, these individuals will have a much greater absolute benefit from a further LDL cholesterol reduction. So we will need to treat only 43 diabetic patients with previous cardiovascular events in comparison with 62 non-diabetic patients. And this is the same, for instance, for patients who had more recent myocardial infarction, an infarction in the last year in comparison with those, an infarction in the last 2 years in comparison with those who had an MI 2 years after enrolling into the trial, those who had more previous myocardial infarctions in the past, those who have inflammation, those who have polyvascular disease. And you can see here that the number needed to treat in full here was around 55 to 60, is reduced to numbers up to 25. So these patients will have double the risk of events and will get the double of benefit from these treatments. And another interesting thing that we learned from PCSK9 inhibitors is actually that these drugs also reduce lipoprotein little weight. The question that comes is there going to be any benefit from reduction of LP little weight from PCSK9 inhibitors? This is a post-hoc secondary analysis from outside outcomes that actually suggests that the benefit for these patients not only comes from LDL cholesterol reduction with alirocumab, but also by reduction in LP little weight. Of course, this is hypothesis generation, and this study also suggested actually those who had the highest LP little weight levels got the greatest benefits, not only from LDL cholesterol reduction, but also from LP little weight reduction. Of course, only a medication that reduces LPA specifically will be able to prove that reduction of LPA will be beneficial, and hopefully we will have that in the future. The other question that comes is it safe to use PCSK9 inhibitors? And also, is it safe to reduce the LDL cholesterol intensively? This is a fair question, right? And actually, we have evidence that even in very intensive LDL cholesterol reductions with PCSK9 inhibitors, in addition to statins, actually, we reduce the LDL cholesterol, but we will not change steroid hormones like HGH, cortisol, estrogen, testosterone, and liposoluble vitamins. So basically showing that actually there are no significant changes. Even in individuals who attain very low LDL cholesterol levels, we don't find differences in comparison with those who remain with higher values. And also, intensive LDL cholesterol reductions with statins will not harm cognition, will not cause cognition alteration, as has been shown in one sub-study from Fourier that was called Ebbinghaus. So this was specifically tested with objective tests of cognition, and actually there was no change at all in cognition, even in those who attain very low LDL cholesterol levels. The other question is, okay, what about the levels of cholesterol and the risk of events? Of course, when we give the PCSK9 inhibitor, we will have lower risks, lower LDL cholesterol levels in comparison with those who do not take these drugs. And the question is it very safe to have very low LDL cholesterol levels, even less than 0.5 millimoles per liter or 20 milligrams per liter? Apparently, the answer is yes. This is data from Fourier, actually showing that there was no difference in these severe adverse events independently of the attained LDL cholesterol levels. There was no difference in the events that led to discontinuation of treatment, no increment in the risk of cancer and cataract. And as you can see here, there was no increment on the risk of new onset of diabetes. As I told you before, statins may increase glucose and precipitate diabetes. Actually, Mendelian randomization studies suggest that actually loss of function mutations, not only in HGMG-CoA reductase or NPC1L1, that actually are the targets of statins and ezetimibe, but also loss of function mutations in PCSK9, that is the target, right, of the PCSK9 inhibitors, may be indeed associated with a greater risk of onset of diabetes. However, in the clinical trials, actually there was no increment. This is data from a group of pre-diabetic patients from Brazil and from France that we did together with Dr. Stéphane Rami Mangata and Gilles Lambert and Bertrand Carriou. And we can see here that after a follow-up of 4 years of 1,751 patients with elevated fasting blood glucose, there was no association at all of circulating PCSK9 levels with the risk of new onset of diabetes, suggesting that actually if you reduce the circulation PCSK9 levels, and that's what these monoclonal antibodies do, we might not precipitate or cause diabetes. And actually, not only on that, but also no association at all of very low LDL cholesterol levels, as I said before, with neurocognition, elevations in liver enzymes, elevation in CK, non-cardiovascular death, and hemorrhagic stroke. So suggesting that actually intensive LDL cholesterol reduction, at least in 3 years, is very safe. So what is next for the LDL cholesterol and for the PCSK9 inhibitors? So actually, not only the monoclonal antibodies, but also we might have other therapies. The one that is most advanced is a small interference RNA for PCSK9. Actually, basically, what it does is binds to the messenger RNA of PCSK9 in the liver and blocks the production of PCSK9. So we will have a reduction in production, differently from the monoclonals that bind the circulating PCSK9. The good news about this is actually this can be achieved with 2 to 3 injections per year, differently from the monoclonals that we might give, let's say, between 24 and 12 injections per year to reduce PCSK9. This drug reduces LDL very intensively, up to around 50%, and apparently there's no sign of safety of these medications. And also we'll have another drugs like oral PCSK9 inhibitors that are also being developed for the near future. So one can conclude that actually cholesterol causes atherosclerosis, PCSK9 regulates the expression of the LDL receptor, PCSK9 inhibitors add robust LDL cholesterol lowering to statins, can be used in patients that not take statins. These drugs further reduce LDL and also further reduce cardiovascular events. Of course, the greater the risk of events, the greater will be the benefits of our patients. That's why we need to do risk stratification, even in secondary prevention, but it's not so hard, as I showed you before, and this will show a greater cost effectiveness. In addition, there's no sign at all of safety or bad safety with these drugs, right? So even the monoclonal antibodies are very safe, and actually low LDL cholesterol and cholesterol apparently is very safe. In the future, we will have other therapies that will make our life easier and make easier to treat our patients. Again, I really like to thank you very much for giving me the opportunity to talk in our Congress, and I do hope that in the future we can be together again. Shukran, thank you very much.